We are live on Podbean. We are live on YouTube. We are live on Podbean. Oh. How do I stop that? We are live on YouTube. Okay. No more echo, right? Good. Sorry about that. That's neat. The Zoom has all of our names listed. Has that always been the case, or?
Are you talking to us?
Yeah, on YouTube, I was just noticing all of our names are underneath our pic. Oh, I've got the wrong picture up there. Hang on.
Lori, do you have a like a schedule or a not so much a schedule, but for the AORN conference
Agenda?
agenda? I mean,
No.
I know it's virtual, so it's not like it's one after the other, but a list of speakers or anything?
I'll see what I can find.
Okay, maybe next time I'll mention the dates, and I was looking at all the posters the other day, but I didn't. And I'm not on my computer down here, so I can't totally see.
We're at 3 minutes. Podbean's announcing to everybody that we're live, and YouTube just announced to everybody that we're live. There we go. We start to see people coming on. Welcome, Denise. I was going to give you a phone call today. I'll give you a call a little bit later, maybe tomorrow morning. You're there.
No, I didn't. Oh, it just came up. It didn't show up on my phone.
Oh. Okay. This is John Goehle with the ASC podcast with John Goehle, and we're about 2 minutes away from going live. Welcome. Zach, can you announce on YouTube how to leave messages? We're at 30 seconds. Stand by.
Welcome to episode 103 of the ASC podcast with John Goehle for May 5th, 2020. Recording live from our studios in Spencerport, New York. This is Susan Cronkite, Chief Researcher for the ASC Podcast with John Goehle, and Senior Nurse Consultant for Ambulatory Healthcare Strategies. The ASC Podcast is sponsored by Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG Patient Lending, Medicus IT, and our newest sponsor, Intelair. For more information about our sponsors, please visit our website at ascpodcast.com. Joining me from our studio in Spencerport is John Goehle, recognized as one of the nation's leading experts in the ambulatory surgery industry. And our other panelists from Cape Cod, Massachusetts, Lori Rodericks, Director of Clinical Services for AHS. From Rochester, New York, Alex Borneman, Director of Operations for AHS. Also from Rochester, Judy D'Ambrosio, Director of Educational Services for AHS. And from Rochester, Jenna Alvarez, Senior Nurse Consultant for AHS. And Atlanta, Georgia, Zach Kaloritis, Financial Consultant for AHS.
And first of all, we probably should correct. This is episode 104. I didn't know how to interrupt you.
Episode 104. Oops.
Oh, well, not a big deal, I guess.
Just
So I hope everybody is faring well. I hope everybody can see our new beautiful graphics if you're watching us on YouTube. We have a green screen behind us, so there's no longer looks pretty if we turn off the the green screen effect. But at least we have these nice graphics up there. In this new studio, I'm not going to turn on the thing because it embarrasses Sue every time I show how the studio looks. But we do have new monitors in here. We keep buying more and more equipment, new cameras coming in on Saturday that will allow us to zoom in so you can see. I don't know what we want to see. If you want to get a closer view of our faces, I don't know. But yeah, we're having a lot of fun with the equipment here. Certainly making a big investment in the conferences and these things. Sue, I know everybody is anxious. Probably the most important part about this whole podcast is a puppy update. So
I don't know. Nothing big and new. She's growing bigger. Everybody that sees her on her morning Zoom session said she's looking less puppyish.
Yeah.
But she's doing good.
She's
very sweet.
She's definitely a very sweet puppy, and we love having her. It's a great joy right now. But
we posted on Facebook a video of her attacking one of her toys.
Yeah.
That she was.
It's quite a vicious toy that she has there. I can see.
Yeah. But it's very cute.
Anybody want to share anything that's going on among our staff? Guess not. I leave these sections in the script for people to just chime in. And
it's so hard to
Are we supposed to read those?
We're all quarantined.
I know.
I know.
I think we're just, somebody was saying on the New York State meeting today how fatigued we're all getting, that this is just, it's just getting very wearing on all of us, I think. I don't know about anybody else. I'm just not getting enough sleep at night. And, it's not that I'm not tired, certainly. It's just that I think we're just tired of this.
Mm-hmm.
To that end, we're located in New York State, and New York State has been on pause. I don't remember what those letters stand for, but basically it means that we're supposed to stay home. Only totally essential people are allowed to go to work. And the governor has announced that it will end on May 15th. But as Jenna keeps reminding me, we don't really know what that means because we don't completely understand how pause affects each of us in our communities. So,
and I don't think they know for sure yet either.
Yeah.
They're just watching the numbers.
So we have tentatively set a date to get on the road again on May 18th, but I don't think any of us really believes that that's going to happen here. It would be nice to start getting out and getting things moving again. We have a lot of projects that are on hold right now, new centers that are opening up, and it's a little frustrating that we can't get them started. And I know the owners of those surgery centers are getting very frustrated. Also financially, we all know that it's quite a challenge, even for those organizations that have received PPP funding. I'm going to talk about that in a few minutes as to what that impact is going to be. Alex, you and I were talking before we went live about just kind of reminding people, don't let all of your administrative staff go. Can you tell a couple, not horror stories, but a couple stories? I mean, because it's your clients, right, that let go of their administrator? Yep, Alex is frozen.
And he's muted.
And he's
because he's
muted.
frozen, he probably didn't hear you.
Oh well. Well,
But I think, yeah, the credentialing especially, you wanted to make sure people
yeah. So I
keep up
mean,
on
what we're
that.
finding is that, especially credentialing right now, because you're going to have to, if you've not credentialed um, your employee or your physicians right lately, or they're expiring during this time, that really is not something that has been allowed to expire. So make sure that your credentialing staff is there and working. And of course, you might be bringing on some new doctors as a result of what's going on here if they're not able to work in the hospital. So definitely keep a minimum of administrative staff on board. Alex something must have
I
happened.
think, yeah,
So
I was
he's
going to tell him he was
disappeared.
frozen, but he.
Maybe
So he's
Jenna ran in and strangled him.
We've been waiting for that to happen.
I know. Quite
The
anxious.
only thing is this pause that's keeping it. I'm just kidding.
It's saving him so far.
Just kind of a quick update on Ambulatory Healthcare Strategies, one of the sponsors of the show, and literally all the people that you're looking at are employees of Ambulatory Healthcare Strategies. If
He's
you're
back.
watching, welcome back, Alex.
Thank you.
We were talking about you while you were gone. We're doing very well. All of us, knock on wood, have been healthy. And we are obviously working. Nobody's had a vacation during this entire pause, needless to say. We're
How would
actually,
we even do that?
I know. We're even picking up clients during this time. We've actually picked up two big clients during the coronavirus situation. I think people are realizing the value of companies like ours and how difficult it is to keep on top of the regulatory issues that we have. And I'm glad that we have been here for our clients. Hopefully, those of you that are struggling through this have been able to avail themselves of all the free resources that we're making available during this time on the ASCpodcast.com website. So don't hesitate to reach out to us if you'd like a more permanent solution, if you'd like to consider us in the future. The ASC podcast has also become the ASC industry's leader in virtual conferences. So notice how I didn't call them webinars. I really dislike that term because I just really dislike doing a webinar where, it's just one voice. We have had so much fun, really. I say that, hopefully people are not like rolling their eyes at me. But we've had so much fun doing these virtual conferences. So I encourage you to visit the acpodcast.com website and see the three webinars we've done so far: Infection Prevention Training, which is a virtual conference to prepare nurses to be infection preventionists, and anybody else that's interested in infection prevention. What I found, and I think, Lori, you know this too, is that even administrators who might not have a nursing background can learn a lot by taking that training, because they at least know the importance of that element and kind of get a good feel for how difficult that job is and how important it is to provide that infection preventionist with all the resources possible. I don't think you and I've never really talked about that before, but as an administrator myself, as somebody with a non-clinical background, I've learned a lot over the years about the importance of that position.
Oh, yeah. I mean, and I think it just stresses their need to support that person in the role, and
Right.
to understand that it's a big part of the glue for the center.
So I really encourage anybody that's interested in infection prevention. It's not even interested. I guess that's not the right term I should be using. Everybody should be taking this training, that is involved in administration, so that they truly understand the importance of this area. And this conference that we did, the recording of it, really kind of emphasized not only the important role that existed even before the coronavirus, but how much more important it is even today. Then we did a 2-day conference called the New World Conference 2020, a virtual conference for ambulatory surgery centers. The purpose of that was to kind of, provide individuals who, might have missed some of the state and national conferences out there, some of the same material that national speakers would have talked about if those conferences had gone on. So, and it allows you, I can't remember, was it 14 and a half credit hours? If you're CAS certified, and I think it was 1 hour of CAPES for people that are CAPES certified. Also, remember the infection prevention training also had 5.75 hours of CAPE credit and 5.7 hours of AEU credit. So between those two conferences right there, you would more than make up all of your annual requirements for CASC. And then last week we did the ASC Roadmap to Recovery, probably our most successful conference yet. There was over 100 people that listened to it live. The people are buying access to it to see it afterwards. And it was basically, it ended up being 7. Can you believe that was 7 hours long, everyone?
Mm-hmm.
Yes.
And yeah, well, okay,
You remember.
mostly because of me. But there was just so much to talk about, and I just talked to somebody today about how they listen to every moment of, and this is a doctor who listened to every moment of it because he learned so much from the process and realized all the work that he had ahead of him as he starts up. So go to our website at ascpodcast.com for more information. Sue, another exciting thing that's going on here, I know you're very excited about it, is the AORN Virtual Expo.
Mm-hmm. That's running from May 1st to July 31st, and it's free for members. There's several ways of getting into it. You can they'll have a virtual expo hall. The only part that I've had a chance to look into right now are all the posters, that you usually see when you go to the conferences. They've got digital posters you can pull up and look at all the different innovative ideas people have come up with, and you can stream the education on demand. So there's a lot of
It's huge.
information there.
I'm looking at it. It's amazing. And they even have a happy hour. I mean, it doesn't get better than that.
How does the alcohol come through the screen, though? That's what I want to know.
If anything's on the screen, that's a waste of alcohol. I'm on record right now. But I just clicked into it, and very impressive. Very, very impressive.
Yeah, I'm excited to, and it's great that they give you so much time.
Yes, that is.
Right.
You've got a lot of time that you can spend.
So a couple
kind of
things that are
browsing
important.
through it.
It was free for members, and
Yep.
did I just pay
Yep.
the membership dues that we just renewed?
Yes.
How much was it? It was like, is it like 140?
I don't know. You
I
paid
don't
it.
know. I paid it and I don't remember.
I don't. It
Um,
wasn't a whole lot.
But
So
it's
it
not a
was
lot of money for all that you're
so
getting.
much information that you got.
Yeah.
And really, even because if you were there, you'd have to choose between so many different
Yeah.
sessions and try to fit it in, in a few days this week and see as much as you want to.
It's currently $145
Okay.
140.
for a
Thank you, Jen.
1-year membership or $306 for a 3-year membership.
Wow. So
And
again,
I'll tell you, I've been a member since before 2000. Probably in the 1980s, I think I became a member. And
Before I was born.
no, I'm older than you. Yeah, birth
You
born.
needed to throw that in, like, for what purpose did you need to remind us of that?
I've never gone to one of their conferences.
really,
We've had
So this will be my first one.
go.
yeah.
Yeah, because we were going to go.
Yeah, we were actually going to be there recording a live
Yeah.
episode. Well,
So.
live by that definition, meaning we're going to, get people interviewed.
Mhm.
And, it's only once the coronavirus started that we actually did real live conferences. So,
Yep.
so I think that's a great advantage. I believe you can still sign up,
Mhm.
become a member today, because I think that's what ours didn't expire. We just renewed it, right?
Yeah,
And-
it was getting ready to expire.
Yeah.
And they do say, like you said, some social stuff. Celebrate the Year of the Nurse. Join our digital party with special giveaways, recognitions, and fun resources. So
That's a great
lots
segue.
of good stuff. It is. So this is
Right back
2020, of course, is the Year of the Nurse and Midwife. And so Nurses Week, they've expanded to Nurses Month. And they've separated that into segments, kind of. So week 1 is self-care, which is obviously this year really, really important. I think for nurses and most healthcare workers right now, you're kind of at either extreme. You're either overworked and really dealing with some really, really sick people, and people are really, there have been suicides, and I mean, it's just really hitting people hard. But then on the other hand, there are some people locally, and I'm sure in a lot of places, where people are afraid to go to the hospitals, where nurses are being laid off or furloughed. So I think almost no matter where you are in this, it's a tough time for nurses. So if people can think of something to do to help take care of themselves, then I think it's really important. Week 2 is recognition. Week 3, professional development. So good time to take advantage of some of the
Conferences. yeah.
conferences that we talked about. And week 4 is community engagement.
6 feet apart.
That's. I'm gonna have to figure out some way to celebrate all of my nurses here. I got to admit that it's not one of those things I got to. So, yeah, Sue's giving me that look. Uh-oh, I'm in trouble now.
And it's a whole
About
month.
a happy
No,
hour on
hope-
the podcast.
Just kind of a quick update on the podcast. Our audience continues to grow. We are close to 20,000 downloads. Can you believe that, Sue? 104 episodes,
Yeah.
20,000 downloads. We are by far,
Cheers.
well, really the only podcast out there that has an audience this large that's really totally dedicated to this. But I guess there's one more thing I did want to say. The website is up to purchase access. Didn't we already talk about that? Up to it. So if you want to access the virtual conferences that we've already talked about, make sure you go to our website at ascpodcast.com. But talking about other podcasts, ASCA, the ASC Association, does have a podcast. It's for members only, so it's not something that you can see unless you're a member. And Bill Prentice actually interviewed me yesterday, which was really weird because I usually am interviewing Bill. So he interviewed me for an episode that should drop sometime today. About the PPP program, the payroll, the Paycheck Protection Program. So if you are a member, log in and then do a search for for an ASCA podcast there. It's available only to ASCA members, and as of the time that just before I logged on, that episode was not available, but there is quite a bit of detail. But I did want to talk a little bit about some of the things I spoke of during the podcast about the Paycheck Protection Program. A couple piece of advice. So by now, most of you that are going to get money from the PPP have probably already received it, which means you are running out of time to bring your employees back if you want to be able to have the maximum amount forgiven. So you need to spend, there's an 8-week period of time that is going to be watched. And if you bring your employees back during that 8-week time frame, you're going to be able to get 100% of the employees. There are certain requirements there, but you'll be able to have that amount forgiven of the loan. So the situation there is any employees that you can include in the amount forgiven payroll up to $100,000 annualized. So any employees that earn less than $100,000, you'll get 100% forgiven for those employees, and then for anybody that earns over $100,000, up to the $100,000 for that employee. You're also eligible to have forgiven the amount of the various benefits they have, such as the payroll taxes, insurance, health insurance, and payroll tax. I'm remembering all that, right, Alex? I don't think there's.
Yep.
Oh, and also pension liabilities there is included. You're also allowed to use the money for rent, utilities, and one other thing. Rent, utilities.
Benefits, you said. And
Yeah, the benefits. Sorry, I'm
utilities.
looking at my script here. Rent, mortgage, interest, utilities. So now most surgery centers don't actually have a mortgage on their books, so most of the time it's going to be rent. As long as of the amount that you borrowed under the PPP program, 75% of it goes towards salaries. The PPP program, by virtue of its name, the Paycheck Protection Program, was meant to help cover the cost of payroll during this 8-week period. Now, even if you're not able to use all of that money for payroll and rent, it does turn into a loan at the end of it. If you don't use it all for those purposes, it's still a pretty darn good loan because it's a 1% loan payable over a 2-year period, and the payments are deferred for the first 6 months. So it's still not a bad deal. One of the misconceptions out there is that you would have to return the money at the end of the 8 weeks. That's not true. It just turns into a loan that's not forgiven, or that portion of it. You also have part of the Paycheck Protection Program is making sure that not only are you spending the money on that payroll, but you also have to keep your head count up to the number that it was prior to the coronavirus. And if you don't keep that head count up to that full amount, again, a percentage of the total payroll cost will be only a percentage of it will be forgiven. And I believe if that number drops to below 60%, if your headcount drops to 60% or less of what your total headcount was before, then none of the money can be forgiven. So be very careful about this. One of the things I talked about on the podcast yesterday is the importance of doing a budget here. So that you keep track of the amount that you're spending. You're very careful about keeping very accurate records. We don't know what the record keeping is going to be like. It will be the responsibility of the bank, at least that's what we've been told so far, to come up with some mechanism for auditing the amount that was used. One recommendation I really make is that you put any money that you receive from the PPP program into a separate bank account and then transfer into your operating account only the amounts that would be eligible for forgiveness. And that way you have a really good, clean record of how you use that money. I did not mention beforehand how you ask questions because we really want to make this an interactive podcast, which is the main reason that we do live podcasts. So there's two ways you can do that. If you're listening to us through Podbean, there is a chat function in there. We're monitoring that chat function. You can also email us at comments@ascpodcast.com, or if you're watching us on YouTube, live on YouTube, there's also that chat within YouTube. So please ask us any questions that you might have here. We'll be glad to answer them. Any other comments? Anybody else want to talk anything about the Paycheck Protection Program, the PPP? Ann Geyer's on.
Yeah.
I am.
How you doing, Ann? You said you weren't going to come on today.
Well, I wasn't, but I didn't want to miss it, and I got home earlier than I
Oh,
thought. How is
that's
everybody?
wonderful. Very good. And you? We're just
Good.
talking about the Paycheck Protection Program. Wonderful
Okay.
program out there.
Hey, John, in that program, the numbers, the staff numbers, is that their full and part-time employees? Is that the head count as opposed to other extraneous staff? So for say a center that has all per diems wouldn't probably qualify?
That's where it gets a little complicated. Hopefully you didn't actually, there would have been no need to furlough your per diems because they don't work full time anyway, or they don't even have a guarantee of a certain number of hours. And so, I mean, again, we're not absolutely sure about this. That's why you have to be very careful about the budgeting as you're going through this.
Mhm.
It's really advisable, certainly not to prune anybody off the payroll at this point, so you can keep those headcounts up. But yeah, it would include all of the staff, clinical and non-clinical, part-time and per diem. Because remember, the government doesn't really recognize even a per diem as anything different than a part-timer.
Mhm.
But again, hopefully you were very careful about how you brought people on board, and you still have time to bring them back, of course, on your payroll during this 8-week period here. But please do everything you can. I mean, this is free money basically that can help you during this time frame. And I think one of the comments that somebody made to me is why do I want to bring my employees back right now when I'm not doing surgery? Well, a couple reasons for that. First of all, we're very worried that some of these employees might, frankly, never come back. I mean, I'm afraid that some of our older nurses might just at this point say, "This is it. I'm tired of this hassle." Maybe their employer didn't give them a nice gift during the Nurses Week here.
Maybe.
There you
Nurses
go.
Month. But I think, and also, some of them are going to go to work in a hospital. I can't imagine somebody going to the work in the hospital and saying, "Oh, I'm going to leave the surgery center." But I guess that is something that could happen. So you want to keep them happy, and you want to, keep them engaged in your organization. And there are a lot of things that they can do. I think we all talk a little bit about that. Is what are some of the activities that you can be doing with those employees during this time that you bring them back and you might not be fully utilized. Even if you are doing surgery, you're probably not doing the volume of surgery that you were doing prior to the coronavirus, which means that in order to bring back enough employees to be able to get the full amount of the forgiveness, you're going to have people not working at their full potential. So let's use this time for education. Let's use this time for getting caught up on all of those things. One of the things I mentioned to Bill yesterday was and Lori and Ann, you'll probably agree with me on this, is that so many times I go into a surgery center doing a survey, and I ask the question of an employee, have you read the accreditation manual? Or I'll ask the question of the nurse manager or the administrator, and I'm shocked to find out that they did not read the accreditation handbook or did not know it, by heart, like all of us here do. So this is a good time we might not have a better time to kind of introduce everybody to the 8 core chapters and the Triple HC handbook and the very complicated chapter structure, which I've never been able to learn in the Joint Commission handbook. So introduce them to that and help them to learn more about the accreditation process. Anybody else have any comments about other things that you can do with your people as you bring them back from the PPP under the PPP?
And I think in just a general way, how we talked about people getting out of practice. So the more people can be back in the center, hands-on things, even if they're, not yet doing procedures, but just kind of, she said, looking through the policy manual, checking the emergency cart, just keeping themselves familiar with all of that clinical stuff.
Well, and one other comment I make is that we know how cross-training can be so useful. And I'm not just cross-training pre-op and post-op with, the operating room, but even, and not so much cross-training people in the, on the nursing side with people in the business office and vice versa. I mean, this could be a rare opportunity to kind of get everybody to learn a little bit about everybody else's job.
Yeah, and not just their jobs, just building that team spirit kind of.
Yeah.
I mean, how often do you get a chance to actually talk with each other and bond a little bit and doing,
Right.
like I was saying, some of those posters I was looking at, I thought it looked like a cool idea to do some training in sort of a escape room way. And usually
You're talking
any
about
of
the
those-
ARN conference, had
Yep,
a couple of these
yep,
sessions.
sorry.
Yeah.
And I think most of that stuff you don't have time to do on a regular basis.
Right.
So if you can do some, do some things where there's learning involved, but also that team building,
Yeah.
it's a good time. I mean,
I've always felt that it's extremely important to get the business office to learn more about the what goes on the clinical area, and just as important to get the nursing staff to understand the role that administrative staff has in the organization.
and sterile processing, interacting with, the people that are actually using the instruments that they're
Right.
cleaning.
Yeah, I have a center that's doing what they're calling shadow days. So that like one of the nurses spends the day with the scheduling coordinator so that they can bounce ideas off each other and each of them can have more appreciation for what the other does.
Yeah.
It's just a way to, well, again, build that team spirit, which is so important. And you get so used to your day-to-day, you don't really think about what everybody else is doing.
Or do you have
Judy,
newer
that works
nurses
both
for instance-
ways.
Sorry, go ahead.
Go ahead.
Sorry, Sue. It works both ways because this doesn't always understand all the parts of the puzzle take place and why she has to adhere to the time frames that the nurses have asked her to. We did something similar to that with the doctor's office schedulers. And
Great idea.
they would argue with us about it doesn't take him an hour and a half to do an arthroscopy and blah, blah, blah. And we said, you don't understand. So we invited them in, got permission from everybody. And oh my gosh, you talk about an eye opener, and we didn't get any from that point on.
I'll bet you didn't. Great idea.
Yeah.
So again, try to take full advantage. I think our levels are dropping.
I know it sounds
I
quieter,
don't
but
know what's
also,
happening here.
and I was going to say, if you have newer nurses in the center, or even people that just don't feel strong in a particular area or on a particular procedure, pair them up with somebody who's more of an expert, and use this time to really build their skills and their confidence.
So again, do what you can to take full advantage of the PPP program and be very, careful about the calculations. Keep very good records of this. We at AHS will be, and we'll try to do something with the podcast too, really trying to develop some tools as we get more information about what type of reporting is going to be required. So I wanted to check in with everybody on our team. Alex, I was going to start with you. So Alex, of course, is our Director of Operations for Ambulatory Healthcare Strategies. He's a life safety expert also. And so Alex, tell me a little bit about what's going on in your world right now.
Absolutely. And actually feeding off of what you guys were talking about before, things that employees can do while they're at the center and you're paying them, life safety checks. There's a lot of weekly, daily, monthly checks that need to be done. And a lot of those can be done by any of your employees as long as they get a little bit of training. So some of the questions that have come up with as far as life safety issues go is how a lot of us are not letting our vendors into our ASCs anymore, or we're trying to be very selective. So how are we selective with our contractors that are performing a lot of these life safety checks? We want to check all of our biomedical equipment, but somebody has to actually come in and do that. So what precautions are you putting in place, and when are you letting the vendor in? Is it on patient days, or is it before the patients arrive? I highly suggest before the patients, hopefully days before even the first patient, especially with those annual checks. And wanting to point out again that maintenance staff are essential workers. That hasn't changed since the beginning of this, but it's important to stress again as we are bringing people back on board, making sure that maintenance staff are among those. And also something that's come up is air changes. It's not a bad idea to check what your air changes are. I don't think all of us know exactly what that is without talking to our contractor or looking it up.
I was just going to say, Alex, because you say that as though everybody in our audience is going to understand what an air exchange is. So what we mean by this is how many times does all of the air in an operating room or any other room, but mainly we talk about it in operating rooms or treatment rooms, how many times does it change or completely get replaced within an hour period? And the normal number is, was it 15.3? It's 15 air exchanges per hour, with 3 of them being with outside air.
Exactly.
But under the situation, it has changed. Talk a little bit about what the new recommendations are. It's not a requirement, but it is a recommendation under COVID.
Right, and it'll be very specific to whether your center wants to go to 99 or 99.9% accuracy. I would direct you all to the CDC website. They have a very nice table there that says, okay, this is how many air changes per hour I have. This is how long I have to wait in between each of my procedures for basically the coronavirus to be definitely out of that room with 99 or 99.9% accuracy, basically. So that's definitely something to take into account, and you'll probably need to talk to your biomedic or your HVAC company in order to figure that out.
And we should probably note that we had an extensive conversation about this whole topic during the ASC Roadmap to Recovery video conference that we did last week. So if you want more details, again, visit our website at ascpodcast.com to get more information about that conference.
Absolutely. And this is a good time too for your staff to become very familiar with your manufacturer's guidelines, manufacturer's instructions. I can't tell you how many times I've asked all of our infection control nurses and or the rest of our staff, what do I do with this instrument? Or, how many times we've been asked that, and how do we clean this? Or can I use a cavi wipe on it? That's what those are for. You have to really become familiar with that and know how.
The answer is always follow the manufacturer's instructions for use.
And don't
I
assume that you
so,
know what they say, because this is. I mean, I appeal to my other surveyors here. That's what I find whenever I'm asking questions, and this isn't not so much in the life state. Now the volumes have gone up again. That's so weird.
Because you're talking loud voice.
How many times have we looked at the equipment that we use for waiver testing, and they get a new set of pregnancy tests, and they don't bother to read the
They
IFUs
know
for
how
it, and
to
then there's
view
new
it to them,
instructions on
but
it.
they don't realize they might be a little bit different.
That's right.
And some people, not every center, it's even clear exactly where those are kept, or their, their chemicals information or any of that stuff. So it's a good thing to make sure people almost do a
Right.
treasure hunt, or
Right.
or tour around the place, make sure everybody knows where all that stuff is.
Yeah, that's actually a good point, Sue. Is maybe a time for one of those treasure hunts. Go
Yeah,
on. Alex. Sorry, we keep interrupting you.
Oh, you're good. And during our shutdown procedures, it came to light that there's some equipment that shouldn't actually be unplugged, or if it was that there's certain startup procedures that need to be done with it. So that's very important as we plug all those instruments and machines back in, making sure that we're doing it properly. And also fire drills. Now is a great time to do fire drills, and maybe if you've already done one virtually, you can do it in person now, depending on what the the precautions you want to take are. You know, actually sounding the alarm and evacuating, both would be very important.
I was thinking, actually, it made me think when you were talking about doing the monthly checks, that this is a good time to maybe bring other people into, say, the nurse manager or the administrator is always doing the exit light checks or the hand hygiene monitoring or anything like that. We always tell people when we go into centers, you can spread that out, you can delegate that, but who has time to train somebody and to walk them through it? Well, now is a good time. And then moving forward, that's something off of your plate. And plus, you get that buy in from other people that are maybe, will be a little bit more excited about their job coming back, that they've got a different responsibility.
Right, and I can't tell you how many times I've talked to a facilities person and they've said, I don't know why I do this, but they told me to check this, push this button every month and record it on this log, and
Oh,
now it's great. It's a great time to tell them why.
And at what point to talk to somebody about it, because people writing down the wrong temperature on their med fridge.
Right.
Well,
Alex, you were talking about the IFUs. I was in a center doing a survey. They had all their IFUs, but nobody knew where they were.
Yeah.
Ones that involved all of the SPD, which is where so much of it is. When they found them, they were in pre-op in a cabinet. And it was like, well, in my head, I'm thinking, well, how often are you looking at these if you didn't even know where they were?
Yeah.
And I think that people fall back on well, that's how we've always done it. And it's always been fine, and we don't have an infection rate. And unfortunately, we can't do that anymore. I mean, the reason we have things is that we're supposed to use them. And it's almost like saying, okay, for 30 minutes sit down and look at the IFUs and go through them. I don't know what the solution is. There's a part of me that's very cynical about how people are really using these.
Yeah, I've been in centers where the policy manual and all the IFUs were locked up, and that's not doing anybody any good.
No.
Yeah. If there's dust on them, that's a problem.
Yeah.
Or they're yellowed. Well, maybe yellow isn't so bad, but.
Or they're all thrown into one binder. They're not sorted in any particular order, even alphabetical. If you needed that one to do something, you'd never find it.
Mm-hmm.
Yeah. Mm-hmm. Anything else, Alex?
No, I think that's it from my end.
Okay, Jenna and Lori, let's talk a little bit about respirators.
Let's not.
I think we are all so tired about talking about N95s, but
So tired of respirators.
Yeah, but tell them the big news. This is the important thing to get across, I think, today. Nothing else from this podcast. You should understand this concept.
What would that be?
Look at your script.
It's just things that our centers aren't used to doing because they've never had to use N95 masks before. It's old rules.
That's right. That is very true.
See, the thing,
I just had to pick on Lori for a second. You know, we talked about instructions for use. Like our instructions for use for the podcast is looking at the script. Now, when we say script, we're not reading from a script, of course. We have like an outline. But
She has it. She's looking
I
at
hope I hope she does a better job with her IFUs than she does with.
just to make it clear to the audience, if Jen didn't send me the script, I wouldn't have had it. So, Mr. Oswami, I
Swami.
didn't
I
get
think
that
the
from
email
you.
said I'll be sending you a link, and I didn't really ever see that link.
Okay, good. Thank you. Thank you. See?
Oh,
But actually, if any of the centers out there, whether they're your clients or not, our clients or not, have instituted the use of any kind of respirator other than the usual surgical or procedural mask, OSHA requires that they have a respiratory protection program. So, surprise, if you have them, you better write it.
and for our clients, we have written it.
Yeah, and we're constantly revising it, so I can't wait till we hit send, but I actually just sent another little tweak to Jenna, but it is required, and it's in that policy, it talks about the fit testing and the seal testing, and also a medical
Yep.
clearance that you have to perform for your staff. We're
Training.
go ahead.
Training and education.
Yeah. And also that needs to be performed. So I think even if you're not using any kind of a respirator, if any centers out there, still do a risk assessment just to show that this is why we're not using respirators. If you do procedures that you never have any aerosol generating, byproduct, if all your patients are local or MAC, if you're never intubating, then you put that in your risk assessment. There was last week on our virtual webinar podcast, whatever you want to call it, John.
Use the W word.
don't use a webinar.
Someone brought up the fact that if you're doing CPR,
Yeah.
respirators required, which blew my brains out. And, I never thought of it because being an old, be quiet, Alex, old OR nurse,
Nodding furious.
I'm thinking operating room. I wasn't thinking anywhere else in the facility. I wasn't, back in the day, we had a doctor that had to get coded in the doctor's changing room. And that's when they discovered the crash cart didn't fit through the door. It's just stuff like that didn't, out of sight, out of mind. I'm not thinking about it. So, again, you make that assessment for your center, and then you move forward. But if you have respirators, you have to have a protection plan, and you have to, your governing board has to delegate someone to oversee the program.
So it's yet another thing that has to be included in your annual appointments.
Yeah. So thank you.
And again, as Jenna said, this is not something that we normally are used to doing in a surgery center. I mean, how many times I don't remember ever having to use a N95 mask in any of my centers over the 30 years I've been in the industry.
I've never been fit tested in my million years of being alive, because
In general, you don't accept any patient that would have some, in general, most centers do not accept someone who has an illness that would require an N95. But right now, where we're in such an unknown
status.
Yeah, a lot of centers are choosing. Now, once we get to a point where we have accurate testing, and again, this would go into your risk assessment, we might be able to eliminate the need or the feeling of the need for them.
We're getting, and John Van Valkenburg just mentioned, we're getting a lot of background noise, like a television is on in another room.
It kind of let up for a minute, but it sounds like
it looks like it's actually coming from Judy's.
She just put herself on mute.
Okay.
Is it gone when I'm muted?
Yeah.
There you go. I can kind of see on this on the monitor here. So thank you, John, for bringing that up. We
Judy's
could
got the
hear
whole family home, so.
Thank you for listening.
So important takeaway is that if you are using N95s, as most of you are in some format, you're going to have this respiratory program, and there is information on the OSHA website. If you do if you do a search of the OSHA website for respiratory protection program, it'll actually pull up a document.
1910.134.
There you go.
1910.134. That's the OSHA requirement. And then within that, it has all the ABCD 7 things,
And a point I need to make here, I wrote it in the script. Remember that OSHA has no sense of humor. They this isn't like CMS. Lori and Ann and I can come into a center and we cite you, and then you got to fix it. OSHA comes in and finds something like this, and they fine you. We don't have that power, but OSHA can fine you, and not only do they fine you, but they fine you a significant amount of money. Sometimes 5 figures or more. So make sure that you're not giving them any excuse for doing that. So look into the infection program if you are a client, of course.
Did
GS
you all, John,
HS
did
will
you
do that for
see Ask a Connect this morning, the discussion about the type of anesthesia determining whether or not I think it was the air exchanges needed to be done? Did you all see that?
Yeah. Yeah.
So if you did MAC, you didn't necessarily have to wait, but if you did any kind of general or intubation, you had to wait. I didn't
Yes,
know.
what Ann's talking about is the amount of time between procedures that you
Yes.
need to wait for the room to have cleared out any particulates that you want to move out. We did talk about this last week during the live conference, right?
Yeah. It's if you're doing an aerosol generating procedure, then you would want to follow the guidelines for letting the air exchanges filter your room.
If you're assuming that all your patients are positive.
But even if you're assuming your patients are positive, if you're not doing a procedure that's going to generate their respiratory increase,
Aerosols.
then it's just like having them in your lobby. You're not going to be doing your air exchanges in your lobby. So if you're doing procedure on my bunion under MAC, and I'm just laying on the table with my mask on and maybe some supplemental oxygen that I'm inhaling, you don't have to worry about the air exchanges. But if you're doing a sinus procedure on me, you're going to wait for that air exchange. Or if you're doing general anesthesia where I've been intubated, you're going to wait for those air exchanges to occur. That's the recommended guidelines right now.
Okay, the only reason I brought it up because I think people are still confused.
Yeah.
I mean, if you look at how the back and forth on that. So I was hoping, if there's anybody that wasn't on our podcast last week, this might help them, but I appreciate that.
Right. And again, each individual center can decide themselves. If they want to do it for 100% of their procedures, then that's their choice.
Yeah.
But it should be in their protocol or their policy that they've created for this type of situation. So, if you overdo it, it's not going to hurt you. But if you underdo it, it may. As long as you can justify the decision you made, that's the main thing to start with.
Can we
Thank you.
veer off of our outline just for a second? Because one of the things that has been coming up quite a bit, and I don't know why I didn't put this into the outline, is the issue of elective versus non-elective procedures. Quite a bit of my time over the last 72 hours has been dealing with our clients and the questions of what is elective versus non-elective. And this is being generated, especially in New York State, because in New York, the governor announced that we can begin doing elective procedures, the hospitals can begin doing elective procedures, but the surgery centers can't, assuming that they can meet certain criteria. And that generated a whole conversation about, why can the hospitals start doing that before we can?
Pretty stringent
Yeah.
circumstances they have to meet too.
Right, and right now the situation is that there are very few hospitals that actually can meet the criteria to begin doing the elective. But it did start the conversation about elective versus non-elective. And one of the things that we know just from Ambulatory Healthcare Strategies clients, at least for now, is that most of the centers that have shut down the centers that have shut down are considering starting up again. But when they're considering restarting, they're thinking about doing elective procedures. We do need to remind you that you are still allowed to do non-elective. And one of the conversations we've had quite a bit lately is, are some of those things that were elective 6 weeks ago still elective, especially in the GI area? After a certain period of time, those things get worse. Pain management, that issue's come up also. So I just wanted to kind of throw that out there, to our panel also, talk just a little bit about this situation. So two parts of this is that if you are shut down and you're starting to think about restarting again, and the main reason that you shut down is because you can't generate enough cash to be able to pay the payroll. Now with the PPP program, you might be able to start back up again, doing a limited schedule of, shall we say, non-elective procedures, and still be able to generate enough cash to keep going. So that's one thing I would encourage people to start thinking about, just to be able to kind of keep things moving, to get ready, to ramp up as quickly as you can, when electives are allowed again. But one point that has been made to me, and that I've had conversations with, especially our GI doctors, is those situations that might have been relatively minor, 6 weeks ago, are no longer that situation. People might be getting, their colonoscopy or their upper GI situation might be getting worse. Maybe there's more bleeding. Maybe they're suffering more. Pain management is another area that we really are worried about. People, the longer that they go without that medication that they're used to having, are probably getting into a worse situation, maybe even requiring more opioids, which we know is not a good thing. Any other observations from my panel here about that and their thoughts on that?
Well,
I think just
oh, sorry. Go ahead.
just going to say, like you had said, weighing the risk versus the benefit and having that really deep discussion, maybe between a couple doctors,
Yeah.
and whatever the decision, if you can back it up and document that decision, that process, and just show that you are looking at each individual
Situation.
instance and
Yeah.
deciding what really has become urgent at this point. That's the important thing.
Well, like what's been discussed for the restarting of your centers, whether it was via our virtual discussions or, ASCA or any of those other things, you're going to be looking at the new criteria that you set, as in for your patients, but also for your procedures. And part of that criteria is looking at the cases that you had canceled. And that's where you would start, besides knowingly urgent coming through, but you would start with those to say, okay, who did we put off that really shouldn't be put off for
Yeah.
this extended period of time? So that would be a really good place to start, is looking at who we didn't do, who we postponed. Are they able to wait another 6 weeks, 4 weeks? Because it's already been close to 8 weeks for them. So, for any one of your practices, whatever your specialty is, that's one way to look at it. Is it going to cause them harm?
I had a board meeting this morning with one of our clients, and they were. It was a good conversation because one of the owners confronted. It wasn't confronting, just questioned another one of the owners who was doing pain management procedures, and he says, how are you justifying those cases? How are you justifying continuing to do them? And the pain doctor, did an excellent job of explaining his situation in quite a level of detail, especially talking about the opioid situation and the type of pain that his patients are now are suffering. And at the end of that conversation, everybody on the board totally agreed with the position and what he was doing, and I encourage them to make sure that we document that fully and document the fact that somebody questioned that. In other words, not just sitting back and saying, "Oh yeah, we probably better not put that in the minutes." No, put that into the minutes because it shows that you as an organization are really questioning everything that's going on, and that the doctors are not afraid to confront each other about their practices, as long as you can justify what you're doing, of course. Yeah, and
Don, you just made, oh,
yeah.
excuse me.
No, go ahead.
You just made a great point about minutes from governing body meetings or QAPI. I worked with a practice administrator one time that they had actually put her over the ASC. And she wanted nothing in the board minutes that could be traced or could be used against us, no details at all.
Yeah.
Well, the doctors that were not at that meeting, if you read those minutes, you had no clue what was discussed, what had gone on. Can you weigh in on what your advice is? Like you said, definitely put it in the minutes. I mean, we're going to be as surveyors, and as CMS comes in, we're going to be looking at that. What's your advice?
Absolutely. I've always erred toward documenting well. I mean, be very careful not to be very specific about cases, for example. You don't want anything because that information is discoverable. But the more documentation you have there as to what your decision is and your decision process was, the more likely that you'll be able to justify that in court if you are sued in the future. Or if you're called on the carpet in this situation for keeping open when when there is a government order not to. When I walk into a center and I only see, one page of notes from a board meeting that went on for 3 hours. I mean, I've had board meetings that I can document in one page, and those are usually, okay, I had to appoint somebody. But generally, those minutes need to be pages long. 4 to 5 pages are not uncommon for most of our centers to document fully what's going on. So, to that end, and, we should have a conversation in the minutes, or the minutes should document that Dr. Smith talked to asked Dr. Jones about, the number of cases that he was doing. Don't be afraid of this. I mean, because
I agree.
this is how you justify that. And then when somebody fights that, you can point to the minutes and say, we had that argument. We did disagree with it, but this is the reasoning behind it. And then that turns the tide on the person that's questioning that. That forces them now to argue against what your decision was. And
Yeah.
it makes for a very different conversation.
Well, the other thing you're proving is that the board actually was involved, and that there's corporate liability that the board has assumed to oversee every part of the operations and financials. And I mean, that would be my argument too. I just wanted to point that out.
Absolutely. Very good point. Anybody else want to weigh in on anything else on elective versus non-elective? I think this is a conversation that we're going to have to continue. We'll continue to talk about it, on the podcast, of course, as we start to ramp up those procedures. I think we need to make it very clear. We talked about this last week during the roadmap conference, that please don't believe that you're going to get up to your full volume in the next couple months or 3 months. It's going to take a while. Everything is going to be different. We spent 7 hours talking about this last week. Everything is going to be different. Your cleaning processes are going to be different. You're going to be socially distancing your audience, your patients coming in. You might have to, you might have to wait for air exchanges. You might be sitting around there, in the center, just waiting for the air to, we've never had to worry about that before, but we've got to take every precaution possible in order to protect our patients here. And that's going to mean that it's going to be a slower schedule. It's going to mean that we're going to be working longer hours. It's going to mean that we might be working on Saturdays, maybe even, heaven forbid, Sundays, in order to be able to keep the volumes up that we had before. I don't think any of us here believe that we're going to reach full capacity or our full volume levels, for another 6 months. So be prepared and prepare your doctors to understand that they are literally desperate right now to get back to work. And I understand it. I mean, their revenue has slowed to nothing. And they need to get back to work, and of course our patients need to be served by this, and it's going to get even worse if the hospitals are the only place that they can get this surgery done and they can't even open yet under, like in New York State, that's going to hold off. And we have the capacity to be able to do this, but somebody has to step in and start making some decisions about the safe way, to start doing these procedures that are going to be backlogged. Okay, Judy, you've been very, very busy lately as the director of our educational services. Let's just talk a little bit about what's going on. And I think one comment that I kind of want to lead off on this area is that just kind of reminding everybody of the annual mandatory education requirements and the fact that, every year you're going to have to do mandatory education. And that education is broken into two different elements. One is that which you can do that is kind of generic. I don't like using that term generic, but that's that education. It doesn't matter what center you're talking about. You can get the education. A lot of this can frankly be done online. There's services out there like MedTrainer and HealthStream, both excellent sources of online educational programs there. And they're great for doing this education that can be done for any surgery center, but you are going to need to supplement it with in-house training that is specific to your center. Judy, can you just talk a little bit about those things that kind of the difference between those two different elements? What can be done for all centers, and what needs to be personalized to your center?
Certainly, of course I can. First of all, yeah, John makes a good point. Remember that we have to do mandatory education. Remember that if it's one of the things you haven't got your people working on now, now's a perfect time. But John's right.
Let me get that in recording. I'm sorry.
Oh, stop.
Judy, be careful with your background noise. We're having some problems again with your background noise.
See, with my headphones on, I can't hear it. But wait. Hold that thought for 1 second.
Sure.
Go kill somebody.
So for those of you that are not watching on video, Judy has left in front of her computer. She's turned her sound off, so we're not.
No, Allie, run.
Screaming.
He's back.
And we will not tell Judy what we just said about her while she was gone.
Sure.
Thank you, Judy.
Is that any better?
It is much better.
Okay. So the point that Sean's making is that you can get your education on bloodborne pathogens and OSHA operating room safety and all of that from anybody, from any source. And there are some really good online sources to get that. But you can't let yourself believe that that's all you need, because you are going to have to do some things that are specific to you, your people, in your center. You need to train your employees every year on your hospital transfer program. What hospital do we use, and how do we go through that? And your actual policy on a hospital transfer. It's beyond just telling them what it is. They all know what it is, but they need to know what the steps are that were written specifically for you. You have to go through programs. Some of, you have really well, if you're one of our clients, you have really well written programs, your cooperative program, your infection control program. And your people need to know exactly, one, that it's in place, and what you expect to be done, what your expectations are, what's been written in that program for you. And no place online is going to be able to do that. You're still going to need that stuff that's done specifically for you. And although you can get, I don't want to use the word generic either, but I can't for the life of me come up with a better word. That PPE, that HIPAA, all of that stuff that we learn every year, and each of your people could probably teach it as well as I could. You can get that from anywhere, although I suggest you get it from us, But remember that you need to bring some people in to help you with the education that, someone that doesn't know you, doesn't know your people, doesn't know your center, isn't going to be able to do, and certainly not be able to do well. John and I have been working, during the craziness, is how I refer to it now, to get some of that stuff online, recorded, that can be used over and over again. And if you are one of our clients, we can make that available to you, and we can also make available some things that are a little more specific, a little more engaged for you. Now, please don't get me wrong. I really want to get in my car, drive to your center and talk to you, because I'm losing my mind. And I want to come in and do that. And
you want to get away from your children too. I mean, I'm assuming.
I enjoy them most of the hours of the day. But I do want to let you know that we're working really hard to try to give you resources that you can use. And if you aren't one of our clients yet and still want, to have these resources available, we're going to work as hard as we can to give you a good product that you can use, not just now for craziness, but for going forward.
So this is what we're up to, is that Judy and I, actually Judy, is working on putting together this.
With really good guidance from
That's right. So we're putting together that generic educational program. We're hoping to, hopefully by tomorrow morning, we'll make a decision as to when we're going to do this. And we're going to record it live, just because it's nice to have a live audience when we're doing it. We know that we won't have a lot of people probably that are going to be able to avail themselves of that. And it will be free for AHS people, of course, and we'll make it available for non-AHS. And then more importantly is that we'll also record this so that this will be available for you to be able to do this. So this would be a really good way. Even if your mandatory education isn't due until, say, September, October, it's probably not a bad idea to just do it now during this downtime. We always know how difficult it is to set aside time in our day to do all this this education. So let's get it out of the way. Then you don't have to worry about it until May of next year. And by us recording these things too and making these things available to you in a recorded format, it's going to make it a lot easier on orientation and for people that are going to miss. I mean, inevitably, not everybody's going to be able to go through that mandatory education during this time frame. So take advantage of this time to kind of get caught up on your annual mandatory educational programs, both the generic part, shall we say, and that is specific to your organization.
Yeah,
And
can we
again-
offer a contest, or there's a prize if you can come up with a word
That's right.
that isn't generic.
Universe.
I said universal and you guys didn't like that.
Oh, well, maybe we'll have somebody vote. Is the people vote on it? How's that?
Okay, thanks. That would be helpful.
And then, and of course, we recognize that a lot of our audience, over 250 people on each episode here, of course, they're not all our clients. So, and many of you do have, I know many of you actually do these programs yourself. So this is a good time, so think about how really not difficult it is to record something. If you have an iPad or if you have an iPhone, you can record this training session. So if you're doing it yourself in-house, just have somebody sit down with, put your camera on a tripod, or for heaven's sake, I guess you could hold it for that whole, 3 hours, whatever you need to do in order to record it. And that way you'll have that recording available that you can give to everybody that is not able to attend it at that time. So just a quick little piece of advice there. And of course, reach out to your regulatory consultants if you have somebody other than AHS to kind of push them a little bit into getting this done during this time. This is a really good time to get caught up on that. So thank you, Judy. Any other comments about education any other thoughts on education? Any questions? Our audience has been very quiet today. Have you noticed that? Thankfully, that doesn't happen during our conferences. I think people are tired. I think that's what's happening now. I can't blame everyone for just getting fatigued. Lori, the other thing that we're working on right now is we know when we bring people back to start doing even elective procedures, again, this is not, we hate using this term, but there is a new normal that we're going to have to deal with as we move forward, at least I have no idea how long this is going to go. And we're going to have to demonstrate to surveyors, we're going to have to, and not only do we need to do this because surveyors are going to be looking, we have to do it because it's the right thing to do. We need to do some in-service training for our staff so that they know what is different now as we move forward with elective procedures. Can you talk a little bit about some of the work that you're engaged in right now on that end?
No, because I'm so tired. But what all of you out there will be probably focusing on, whether it's internally yourselves or through others, you're going to want to be able to show that you've re-educated your staff when it comes to their daily work. You have to you want to re-educate them on the PPE, because now there's staff that are using it probably that haven't before. Every one of your staff are masked. Not everybody has ever really put a mask on before. Your staff in your pre and post-op aren't used to wearing masks. Your front desk staff definitely aren't. So you're going to want to go over that. You might be having your PACU staff wear a gown, depending on the type of procedures, the patients that are coming out. If they were aerosol generating procedures, then you want to protect those people. Your staff in pre-op though probably won't be wearing gowns because they're not hopefully in contact with anyone that is going to contaminate them in that way. But that's just an example. Same thing with your physicians, and making sure that everyone's taking it off correctly, or that you're doing it in teams so someone can help someone else remove the back ties and stuff if they have, if you have staff that are limited. Some of us can't get our arms back there and whatnot. So there's that. You're going to talk about hand washing. You're going to really re-educate everyone on the importance of hand washing, the when to do hand washing, the when to do the alcohol-based products. Also to make sure that your alcohol-based products is a minimum of 60% alcohol, things like that. You're going to revisit your environmental cleaning, such as your frequently touched surfaces, and how often you're going to be washing them. And as we mentioned last week, it's not just your over bed table or your handrails, it's also your doorknobs, your phones, your call buttons, things like that. So there's a lot of things that you might not have even thought of before. Your pre-op and PACU area, are there areas that you're going to be cleaning after every single patient that perhaps you didn't before, like the behind the bed, if you have shelving behind the bed, are you going to be cleaning that more often? Are you even going to have supplies there? How about in your OR and your procedure rooms? Any cabinets that you normally wouldn't clean all the handles on after every single procedure, you're probably going to start doing that now. Because number one, it's not a bad practice. Maybe we should have been doing that in January, but now come May, we will be doing. So it's stuff like that. And, re-educating our instrument processing people on, the correct usage of their PPE, and that they are transporting the instruments appropriately from the procedural OR to their room. So there's a lot of things out there that if a surveyor comes in and starts giving you the whatever over your infection control regime and what you have done since the pandemic, they're going to want to see that. So they're going to want to, you're going to have attendee sheets and what you've discussed and what you went over and who attended and then also who didn't attend, that you're going to find them and make sure that they are instructed. Because if John comes in and asks Sally Mae in PACU, oh, did you receive training on putting on that gown and those that mask? And she says no, busted. Will they ask that? I don't know, but anyone out there listening, they might. So it's just stuff like that, and it's just good, safe practice, and that's what it's all about.
Make sure that as you're doing this education, that it's not just the staff, sorry, but it's got to be the physicians too. They have to go through some of this training. I know that's going to be tough, but they need to understand what is going into this new world, shall we say, and how things are going to be different and how they're going to have to react differently in between procedures. And I have to say this again, when it comes to infection control, we all know that over time we have put up with practices that have been less than ideal. I mean, I know so many of our clients over time, they haven't really taken the flu vaccine seriously, and pushed their employees to have the flu vaccine. So I think this now is a really good time to fix any of those practices that have been less than ideal in the past.
And the other thing too is you may find now, and I'm not picking on them, but your anesthesia providers are probably the most sensitive at this time regarding what they need to do to keep themselves safe because of this disease being an airborne and droplet transmitted virus. So they're the ones that are right at the highest point of contact at all times. I'm not saying that they're going to be more diligent with their safe medication practices, but they will definitely be more diligent when it comes to probably hand hygiene, wearing proper attire and all of that. So, you know, there, you might have some really great resources to have as champions now for your infection control program as well.
Go ahead, Ann.
Lori, you brought something up about people are going to be wearing masks who don't normally wear masks. And as an OR nurse, you know, we always couldn't wait to get our mask off in the OR. But imagine being in pre-op and PACU where you're not used to wearing a mask. And I'm seeing this in the stores. I hardly go out, but when I do, people are reaching up and adjusting their masks, and they're telling you to keep your hands away from your face. But our staff, even if they're clinical, they're going to be doing the same foreign body to them. It's something they're not used to doing.
Yeah.
It's hard not to touch your face when you're wearing one of those masks.
Isn't it, Jenna? I mean, I had one on today. I had to go out and I was because it wasn't comfortable for me. It wasn't a surgical mask and it wasn't comfortable. And I kept wanting to slide around and it made me miserable. And I'm used to masks. So I wanted to point that out because that's true. Look at your front desk staff. They don't ever wear a mask. And haven't helped. I mean, that's going to take a big adjustment. They're going to say, I've been wearing them out in public. No, it's not the same as wearing them all day.
Right.
Well, and just, I think the biggest part is if you're going to touch your mask, which I get it, do your hand hygiene.
Absolutely.
Yep. So, you know, there's a lot of people are going to be relearning safe practices that they haven't had to use, but they've heard about or they know about. But now it's going to be, you know, all the time, you know, for now anyway.
I do want to remind our listeners, if you have any questions, I don't think we've had a question today.
I don't think so, and I know we're
So-
coming to the end, so if anybody has any questions about
This is your
anything we've
time.
talked about
That's right.
or not.
While we're waiting
anything.
for people to chime in on those questions, I did want to remind everyone the importance of going to the ASC Podcast website at ascpodcast.com. Also remind everyone that we have another conference coming up. It's in June. It's June 11th and 12th. It is the ASC Finance, Accounting, and Reimbursement Seminar. It's 2 days long, and it is co-sponsored by Coding Compliance. I'm sorry, what is her last name? Yeah, Coding Compliance Management. It's Christina Benton, my dear friend Christina Benton, and of course the ASC Podcast with John Goehle. So we'll have a lot of great sessions there. It's a really great conference for anybody that wants to learn more about finance, and I'm looking at you nurses there. I know none of you nurses, other than Ann. Ann over years has become an honorary financial person, but that's certainly not Lori,
Really not.
or Sue for that matter.
It's a checkbook, so hey.
Um, can you ask though, or just we have somebody trying to call in? Just want to find out.
Yeah,
what
we had
that's about.
somebody call in. If you can just type in
Your question.
your question or your name so we know who you are.
But this is a great conference to learn more about finance, to learn more about accounting, learn more about reimbursement. If you're interested in moving on to become CAS certified, this is a great thing to do. It's available on our website to register, and I think I can't remember. We're in the process of getting the CAS credit lined up, so that hasn't been done yet. Okay, anybody else in the panel have anything else they want to talk about? Any more questions? Okay. Thank you for your time. That's it for this episode of the ASC Podcast with John Goehle. Join us again. We are at least weekly now. And please consider becoming a patron by going to our website at ascpodcast.com and spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, Lori Rodricks, and Ann Geyer. Music is provided by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. We would like to thank our sponsors: Ambulatory Healthcare Strategies, Surgical Information Systems, Encompass Healthcare Data Solutions, BHG, Patient Lending, Medicus IT, and our newest sponsor, Intelare. For more information about our sponsors, please visit our website at ascpodcast.com. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.
Thank you, everyone.
Thank you.
Bye.
Bye.
We are off air.
Okay.
Good job. The number wasn't very high this time. It was between everybody. It was probably about 17 total that came. The highest we had at one point, which isn't bad. I mean,
Yeah. We always know there's a few that aren't even
yeah,
real people.
right. Well, that's that other number, the 30, because you see people popping in like whoever this one guy was. Oh,